What is brain herniation? Brain herniation is a potentially deadly side effect of increased intracranial pressure that occurs when a part of the brain is squeezed across structures within the skull. The brain can shift across such structures as falx cerebri, tentorium cerebelli, and through the foramen magnum. The tentorium is an extension of the dura mater that separates the cerebellum from the cerebrum. There are two major classes of herniation: supratentorial and infratentorial. Supratentorial: 1. Uncaltranstentorial herniation. 2. Central tentorial herniation. 3. Subfalcine herniation. 4. Transcalvarial herniation. Infratentorial. 5. Upward transtentorial herniation, upward cerebellar. 6. Tonsillar herniation, downward cerebellar. Brain herniation frequently presents with decorticate posturing, with elbows, wrists, and fingers flexed, and legs extended and rotated inward. It is a characteristic positioning of the limbs indicative of severe brain damage. These patients have a lowered level of consciousness with Glasgow Coma scores of 3 to 5. Vomiting, severe headache, and seizures can also occur. One or both pupils may be dilated and fail to constrict in response to light. Cardiovascular and pulmonary symptoms may also be present, known as Cushing's triad: hypertension, with widening pulse pressure, irregular respirations, commonly Cheyne-Stokes, bradycardia, and in severe cases, cardiac arrest. A 45-year-old man is brought to the emergency department after sustaining a traumatic head injury in a motor vehicle collision. The patient was found unresponsive and had several generalized tonic-clonic seizures during transport. Medical history includes hypertension as well as alcohol and cocaine misuse. Temperature is 36.7 degrees. Blood pressure is 170/96. Pulse is 50, and respirations are 10. Pulse oximetry shows 98% on mechanical ventilation with 50% oxygen. On examination, the patient is comatose, with mid-positioned and fixed pupils and rigid extension of the upper and lower extremities. Non-contrast CT scan of the head is shown in the image below. Damage to which of the following structures is the most likely explanation for this patient's abnormal posturing? The correct answer is E, pons. This patient, who sustained a traumatic head injury, has an extensive intraparenchymal hemorrhage that is likely complicated by brain herniation. Intracranial, for example, intraparenchymal hemorrhage can cause significant mass effect and increase intracranial pressure, which can manifest with seizures and Cushing triad, hypertension, bradycardia, bradypnea. With further hemorrhagic expansion, horizontal shifts in midline structures or brain herniation may occur. Progressive pupillary abnormalities are common in herniation. Uncal herniation initially disrupts the ipsilateral oculomotor nerve, cranial nerve 3, leading to a fixed dilated pupil. However, as the brainstem becomes inferiorly displaced, that is, central herniation, damage to the midbrain and upper pons typically results in bilateral mid-positioned and fixed pupils due to loss of both sympathetic and parasympathetic innervation. Brain herniation also causes abnormal posturing from disruption of descending tracts, for example, rubrospinal, vestibulospinal, typically involved in reflexive and postural movements. The vestibulospinal tract maintains extensor tone and originates from vestibular nuclei at the pontomedullary junction. The rubrospinal tract regulates upper extremity flexor tone and originates from the red nuclei in the rostral midbrain. It is inhibited by descending cortical input from the cerebral cortex. Damage above the red nucleus, for example, cerebral hemisphere, internal capsule, typically results in decorticate flexor posturing due to loss of descending inhibition of the red nucleus and subsequent hyperactivity of upper limb flexors. Damage below the red nucleus, for example pons, or to the nucleus itself, for example midbrain, often causes decerebrate extensor posturing due to loss of descending excitation to the upper limb flexors via the rubrospinal tract, and extensor predominance due to unopposed vestibulospinal tract output. Choice A. Damage to the cerebellar vermis usually affects balance and coordination of the axial proximal limb muscles, resulting in gait and truncal ataxia. Cerebellar vermis injury may also result in nystagmus and vertigo due to this structure's role in vestibular function. Choice C. The cervical spinal cord is commonly damaged in the setting of closed head injury, which may lead acutely to flaccid quadriplegia spinal shock, that is, absence of flexor and extensor motor tone, due to loss of excitatory input from the descending motor pathways. Choice F. Damage to the substantia nigra can result in excessive inhibition of the thalamus, with subsequent decrease in excitation of the motor cortex. This leads to motor features of Parkinson disease, for example, rigidity, bradykinesia, tremor. Choice G. The thalamus is a major relay station for motor and sensory information, and also help regulate alertness and consciousness. Although bilateral damage to the thalamus may result in coma, flexor-extensor posturing is not characteristic of thalamic injury. Educational objective. Brain herniation causes abnormal posturing due to disruption of descending motor tracts, for example, rubrospinal, vestibulospinal. Damage above the level of the red nucleus, for example, cerebral hemispheres, internal capsule, typically results in decorticate flexor posturing. Damage at or below the red nucleus, for example, midbrain to pons, typically results in decerebrate extensor posturing.